Hey friends, Dr. Corey Babb here. On today's Intercourse Discourse, we're going to look at something that affects approximately 10 to 20% of women every year in the United States, and that is painful intercourse. Now, there's a bunch of different reasons that sex can hurt, but the most important thing to keep in mind is that overall it should not be a painful experience. Do you want to know more? Come join me today as we investigate differential causes and treatments for dyspareunia or painful intercourse. Said, dyspareunia affects around 10 to 20% of women in the United States every year, and it's something that often goes untreated. The reason behind that isn't really well understood, although we know that with a lot of sexual medicine issues, people just don't like to talk about it. We also have this kind of cultural idea that painful intercourse, or really anything related to sex, if it's painful or not wanted or things along those lines, a lot of times just should be something that you should suck up and deal with. So there's a lot of cultural biasing about dyspareunia as well. And so really when we look into it and really look into the research about this really horrible topic, sources are kind of sparse. We have a journal article here and one there and things like that, but there's not really a big collection of collective intelligence and a collective research in what we should do for patients who suffer from painful intercourse. And before I go any further, I do want to make sure that you know that there are specialty societies out there that are really looking into developing treatment programs or paradigms or cures for painful intercourse. So there are subsections of the American College of Obstetricians and Gynecologists, the International Society for the Study of Women's Sexual Health, the National Vulvodynia Association, just to name a few, that do have ongoing research projects about dyspareunia. So if you are a patient that suffers from these conditions, you may consider reaching out to not only your own provider, but to those specialty societies as well, and see if there are research studies that you can get involved with. Maybe you would be the one that would help come up with a cure for something like vestibulitis or vaginismus or things like that. So keep that in mind as we kind of venture forward. So when it comes to painful intercourse, there's a couple of different things we have to look at. Number one, is this something that occurs more with initial penetration, kind of right with insertion, or is this something that occurs with more of a deeper penetration? And obviously I use the term penetration to include anything from penile, vaginal penetration, the use of a finger, sex toy, whatever it may be. So anything that's penetrating into the vagina, you can kind of take into that overall heading. Things that are kind of more with that initial penetration, we evaluate in a completely separate way than we do the deep penetration. The other thing to look at is, are there associated symptoms with this? Do you only have pain in specific positions or specific times of, your menstrual cycle? Or are there other things that are kind of going on, are your kids walking in all the time, heaven forbid, or something like that? So it's not just that cut and dry, but it's a good place to start when we talk about different causes and treatments. So with initial penetration, we want to break it down into one of three different categories. The first is vulvodynia, the second is vestibulodynia, and the third is vaginismus. These are all kind of three V words. That suffix dynia basically means pain. So vulvodynia is pain of the vulva, vestibulodynia is pain of the vestibule. Vaginismus is its own kind of little thing that we'll talk about here in a second. Now, vulvodynia and vestibulodynia can be due to a number of different causes, everything from a hormonal change to an inflammatory or infectious cause, sometimes even abnormalities with the way that the nerves in that area of the body are firing. And so you have to kind of break that down and do some lab tests or do some additional testing to really figure out what's the cause of those vulvar or vestibular pain symptoms. So when I have a patient that shows up that I'm working at for either vulvodynia or vestibulodynia, there are a couple of things that I want to know. Number one, has there been any trauma in the past? Has there been like a really bad bicycle accident as a kid? Did she have substantial tearing with a delivery? Has there been any other type of trauma, like a bad car wreck, something like that? Because that can lead me down a whole set of diagnoses that if she didn't mention, I would otherwise miss. The second is to look at, is she on any type of medication that has a known correlation with painful intercourse? The most common that we see are with birth control pills. Long-term birth control pill use can be associated with a drop in testosterone, and that testosterone leads to a hormonal deficiency in the vestibule, and that can cause a vestibulitis there. And I'll talk more about that in my testosterone video So you can check that out if you want to know more there. But getting that historical context is one of the first and arguably one of the most important things we can do to lead us down a treatment route and diagnostic route for this patient. We can ask a similar series of questions when it comes to vaginismus. Now, vaginismus by definition is uncontrolled spasming of the muscles right at the entrance to the vagina. It occurs almost as a reflex, if you will, to pain. If I tell you I'm going to hit you, a lot of times you'll instinctively tense up as a way to protect yourself. Well, the vagina does the exact same thing. Those muscles will spasm in a response to discomfort or in anticipation to discomfort. And so when asking these ladies, do you remember a time when sex was not painful? Or do you remember, has it always been painful inserting a tampon? Or has it always been uncomfortable to go to the gynecologist, more than it already is? And those are different historical things that can point us down that road. Obviously, a history of sexual abuse or rape plays into all of this too, but you can't hang your hat on that. So that's something that while we always ask, more often than not, that's not the cause of what's causing this discomfort. And if we've done a thorough history, the next thing to do is to think about doing potentially a laboratory analysis. Low testosterone, low estradiol are all associated with painful intercourse. Like I mentioned before, with the vestibule, being a very testosterone-dependent tissue. If that's low, that can cause pain. Likewise, women who are menopausal, whether that's going through a physiologic menopause or something surgical, due to having to have your ovaries removed for endometriosis, or possibly being on chemotherapy for different cancers, all can lead to a more menopausal state. And what that means is that the vagina and the vulva and the vestibule all become very estrogen deficient. And so they tend to get more what's called atrophic, or kind of thinner, kind of more withdrawn. And so that tissue becomes very tender to touch. It can't really accommodate during intercourse. And so those are different things we can look at. And obviously, if we see a very substantial lab decrease, that can kind of go in and make us say, aha, well, we see it clinically, we know that there's something here historically, and now we also have this lab data to back up our hypothesis about what's causing this pain. When it comes to deep dyspareunia, now on the other side of things, we want to know similar things. Has it always been this way? Has there been other, traumas that have happened? Childbirth really plays into deep dyspareunia. But there are other medical conditions that we have to look at too. So endometriosis, diverticulitis, ladies that have any type of inflammatory bowel disease, like Crohn's or ulcerative colitis, and then a bladder condition called interstitial cystitis, which can cause really kind of painful urination, but also can cause kind of chronic pain in that bladder area. Those are all different causes that can lead to deep dyspareunia. And one of the things that we see that either they cause or that causes them, it's kind of the chicken or the egg type thing, is pelvic floor dysfunction. Now that warrants an entire video on its own to talk about, but kind of the brief summary of it is that your pelvic floor is basically a grouping of muscles, kind of like this, that hold your bladder and your vagina and uterus and your rectum all together. And when you walk, they kind of exist like this and support things in. Well, if they become deficient, or if they get torn, or if they're really what's called hypertonic or spasm, that can cause a lot of pain. And just like it hurts if you have a spasm in your shoulder and someone comes along and keeps poking you and you're like, ow, please stop. The same type of thing happens with sex. Any type of deep penetration that's hitting one of those spasmed muscles is going to lead to discomfort. So that's something we always want to keep in mind too. After we've done our history and maybe we've gotten some labs, we need to look at things from a physical exam standpoint. And one of the best tools that I have as a sexual medicine provider is a colposcope. And what that is basically is a big microscope that we use normally in gynecology when we have ladies who have an abnormal pap smear. We've kind of modified it a little bit to look at the vulva and to do a vulvoscopy, or a microscopic evaluation of the vulva itself. And with that, I can see the different glands on the inside of the vulva and the vestibule. I can see little teeny tears. I can see increased vascularity, like these different skin changes that can happen, and different kind of markers that may say, aha, there's a cause for the discomfort. The other thing after doing that vulvoscopy is taking this a little Q-tip and kind of poking it around different anatomical areas. And if I can isolate where the pain is, if I say, well, it's in the vestibule, or it's in your Skene's glands, or it's on your urethra, or whatever it may be, that leads me down a different diagnosis and treatment path as well. The third thing is using a manual exam, so using kind of with my fingers here to feel those pelvic floor muscles and then also to feel those pelvic organs. And if I feel a big spasm, or I feel, say, a big ovarian cyst, or your uterus feels really enlarged, those are all different things that can lead me to a diagnosis as well. So now we have a diagnosis. Obviously, the most important thing is to figure out, well, what do we do about it? So treatment really does depend on what is actually causing the problem. I know that sounds very straightforward, but I get, referrals, or I get patients that come in who have seen other providers that were just given birth control pills or hormones just willy-nilly, when it's not even something like that that's causing the problem. So you really have to tailor the treatment to the individual disease state. If it is hormonal, if it's, say, deficiency in testosterone or estradiol, okay, well, replacing those hormones can really be beneficial in relieving discomfort. If it's a pelvic floor spasm, doing something like pelvic floor physical therapy can really be beneficial in getting those muscles to relax or to properly work together to support the pelvic floor. Endometriosis, we talked about in the endometriosis video. There's medications for that. There's different different surgeries to treat the pain. And then there are other specific medications for very individualized circumstances. So for instance, prasterone or Interosa is a medication that's used for postpartum postmenopausal dyspareunia. That's its FDA indication. There are other medications like ospimifene, which is an oral pill that you take for postmenopausal dyspareunia as well. Some people will try topical lidocaine gels, will try compounded gabapentin, or nerve stimulations, and we also will do for vaginismus patients, sometimes dilator therapy or Botox and dilator therapy as well. So the treatments are too many to kind of list out here in just a table format, if you will, but just know that really in order to treat dyspareunia effectively, you have to know what is causing the dyspareunia itself. I think that's the big take-home message from this video. If you're having pain with sex, you have to know why you're having pain. And once you know that can point towards a good treatment paradigm. So what next? So, how long does this treatment protocol last, or how long will it give me relief? And that's unfortunately a very individualized thing. I can't tell you on this YouTube video here. Really what I would recommend is that you find a provider in your area that is knowledgeable in dyspareunia, that knows kind of what the current treatments are. There are some really good physicians, nurse practitioners, PAs out there that know what they're doing when it comes to treating this. And just maybe a little bit, of working on your part to find them. ISWISH, which, you've heard me talk about before, the International Society for the Study of Women's Sexual Health, on their website has a list of ISWISH providers. And these are individuals that are going to be knowledgeable in sexual medicine conditions. If you're a menopausal patient, seeing a NAM certified menopause practitioner, they'll know more about this than just kind of your average practitioner as well. There are a bunch of different books out there. You can look at. Thorns and Roses is one I helped write a chapter in. It's on Amazon. I'll put the link down here below. But really, the fact of the matter is, there is a lot that can be done for dyspareunia. I don't want you to think that just because it is so common and no one talks about it, that you just have to kind of live through it, because that's not true by any means. There are lots of things that we can do to make it better. And I've had patients personally that have come and who have been unable to consummate their marriage, that now have gotten pregnant and have had kids. So there are treatments that do exist. You just got to start off and ask the right questions and know what you're treating. Well, friends, that's about it for this video. I hope you've enjoyed it. If you do, make sure that you subscribe to my channel and hit that little bell down there to be notified whenever I post any new videos. I'm Dr. Corey Babb, and I hope you have a wonderful day, and I'll see you soon.